Welcome to this video on Arterial Spin Labeling, or ASL, from basics to pCASL. This high-yield teaching deck is designed for first-year radiology residents and covers non-contrast perfusion MRI and quantitative CBF mapping. Why is ASL important? It is a non-contrast perfusion MRI technique using blood water as an endogenous tracer to quantify cerebral blood flow, or CBF. It's safe for patients with renal failure and repeatable for follow-up studies, providing quantitative perfusion data. The core idea involves 5 steps. First, a radiofrequency pulse labels the arterial blood. Second, you wait a post-label delay time. Third, acquire the label image. Fourth, acquire a control image. Finally, subtract the control image from the label image to form the perfusion map. We are measuring cerebral blood flow, or CBF, and arterial transit time, or ATT. The measurement results in tissue perfusion, or TP. It is important to remember that the label decays with T1 relaxation, making timing critical. The ASL sequence includes 4 main components: the labeling plane, the post-label delay, the imaging slab, and background suppression. The overall concept is simple: label, travel, image, and subtract. ASL has 3 main techniques: PASL, CASL, and pCASL. PASL is simple but has low SNR. CASL has good SNR but is mostly historical. pCASL offers the best balance of efficiency and low SAR, making it the current clinical standard. Pulsed ASL, or PASL, uses a short inversion pulse. Advantages include simple implementation and low SAR. However, PASL has low SNR, is sensitive to transit delay, and has variable labeling efficiency. Continuous ASL, or CASL, uses a continuous RF pulse for labeling. It offers high labeling efficiency and better SNR than PASL. However, it suffers from very high SAR and demanding hardware requirements, making it less common clinically. Pseudo-continuous ASL, or pCASL, uses a rapid RF pulse train to mimic the continuous labeling effect of CASL, but without its hardware demands. This gives it the CASL efficiency combined with PASL practicality, offering the best of both worlds. pCASL is the clinical standard due to its highest SNR, high and consistent labeling efficiency, and moderate specific absorption rate, or SAR. It is software only and demonstrates excellent clinical robustness. It is the preferred implementation for clinical use. Timing in pCASL is critical. The recommended label duration is 1800 milliseconds. The post-label delay, or PLD, is typically 1800 to 2000 milliseconds for adults. Short PLD can cause artifacts, while long PLD leads to signal loss. Key pCASL technical parameters include a label duration of 1800 milliseconds and an adult PLD of 1800 to 2000 milliseconds. A 3D acquisition and background suppression further optimize the technique. ASL artifacts include the arterial transit artifact from short PLD, which is the most common. Motion artifacts are frequent. Low inherent SNR is an inherent issue, and susceptibility artifacts are location-dependent. Clinical applications of ASL include stroke, where it is used for hypoperfusion and penumbra identification. It is also used in dementia to assess regional CBF reduction and in epilepsy for lateralizing seizure foci. To summarize, ASL is a non-contrast perfusion MRI. PASL is simple but noisy, and CASL is efficient but impractical. pCASL is the current clinical standard. Remember the core concept: label blood, wait, subtract, and get a perfusion map.